move on to the question and answer session, and I've really only got one rule for this evening. It's a question and answer session, so please don't use your time to make just generalised statements. We're really here to answer questions that you've got at the forefront of your mind. So if you do that, I'll move you on to get a proper question from somebody. Okay. So our first question. Anybody?
Well, my question is, there's all these, I appreciate what's going on.
Sorry, there's a microphone coming and everybody can hear
sorry.
you.
Thank you. No, what I want to know is what's happening about this A&E closures, because as far as I'm concerned, it's closed, it's gone, done deal. Sorry, Mr. Hopkins, but I can't see any other way. It's been dragging on. There's more and more consultancy. No one, there's no MPs or nothing here tonight. Where's all these people that's involved in wanting to close it? It's Dr. Freeman, for example, one of the top notches. So I say it's definitely gone. Sorry.
Okay. So I completely understand your concern, and I suppose there are. I talk to our staff a lot about some of the proposed changes that are being talked about at the moment. And I mean, I don't want to necessarily sort of give you a flippant answer, but I was in A&E the other day talking to one of our sisters in A&E who said, she said, don't worry, Matthew. I started here at St Helier in 1985, and the day after I started was when the first suggestion of closing St Helier's A&E was made. She said, I'm still here, our patients still require care, and she said, I think there's been probably 2 or 3 proposals to make significant change to A&E services in her time as a sister here. So I think we need a bit of perspective here. The first thing I would say is there's no decision. The second thing I would say is that, as I said in my presentation, to close an A&E in the context of 3 or 4% extra people using all of the A&Es in South West London, not just St Helier's, but all of the A&Es every year, will require a massive change in the way in which people are looked after so that they don't require attendance in an accident emergency department to enable one to be taken out of existence. And I'll tell you this, 2 stories. Firstly, when I was a Macmillan nurse, we prided ourselves on working in an integrated way with GPs, with the hospices, with the district nurses, and with the hospital. And even then, with the best possible approach to managing the pathways for terminally ill patients. Terminally ill patients sometimes still came into hospital through A&E departments. So there has to be a radical transformation in the way in which people are looked after to enable that kind of significant change to happen. And I think the second thing I would say is there is absolutely no way that I or my colleagues on the Trust Board would countenance a situation where we go back to the dark days of the early 1990s with frail elderly people lying on trolleys in A&E departments for 12, 24, 36 hours. So we need to be absolutely convinced that proposals are going to work. And for you in this room, you've got the opportunity, when the proposals go out to consultation, to really challenge some of the thinking behind them and to make sure that you feel assured that those proposals will actually work in practice. So I can understand why you might say, well, it's already happened, the decisions have been taken, and I'm of the view that no decision has been taken and that the public has the opportunity, when consultation starts, to ask some questions about how this might work in practice.
Fair enough. I have one more question on something different. If I
Hang on, there's a gentleman behind you.
Oh, but sorry, I apologise, sorry.
Yes, thank you. If I can sort of follow up on that, on the assumption this is going to be an evidence-based decision, can you talk about some of the variables that will be assessed, such as, for example, journey times or the relative levels of deprivation of the populations you serve, that kind of thing?
Well, the information that was used to underpin the decision to develop this proposal showed that there are parts of South West London with a higher deprivation index than in Sutton and Merton, although there are parts of Sutton and Merton that are that would show up as a sort of a red on the map, if I can put it that way. And the journey times factor for people, if there were various other options, so for example if Croydon were to lose its A&E maternity service, or indeed Kingston, as I understand it, and I wasn't there on the scoring day, but as I understand it, the impact on patients was across South West London less for those around St Helier than it would have been for the other hospitals. But I think that's an important question to challenge when the consultation starts, because my experience of working in health service in both clinical and executive roles is that it isn't just about journey times, it's about where definitive treatment happens. And that definitive treatment has to be absolutely top quality to give the kind of outcomes that the fantastic patients have talked about here this evening. So I think what we should be all about is making sure that actually we're looking at quality right at the forefront of these proposals. But I think there will be the opportunity to ask those questions and understand the detail.
Any other questions? Sorry, I'll come back to you in a moment. There's another gentleman over there.
Okay, sorry.
Gentleman in the...
Just a question from the staff side, really, because we've seen the figures about the absence rate, which we need to bring down. But I think there is an immense amount of uncertainty with regard to the future of the trust, and particularly for people working in emergency care elements. It doesn't matter whether it's going to be an elective hospital or an acute care hospital. So the question would be to the executive team, what the executive team is going to do to address these issues and uncertainty, either helping people what could be the pathway for them to work, because this is where we earn the money to live on. So it's really important to us.
Absolutely, and as you know, earlier in the presentation, I did pay tribute to the way in which our staff across the organisation have responded to the challenges and the uncertainty, and actually have. I mean, our A&E performance since May has been second best in London. So that's down to our staff. It's not down to me. So my responsibility and my duty is to make sure that we are understanding how any proposals for change might work, communicating with the staff in the most open way, being accessible, having the opportunities for open meetings as we do to talk through how any proposals might affect staff, and be absolutely clear that the important component of good patient experience is the kind of approach, attitude and skills of our staff, and to continue to invest in those despite the uncertain environment that we're operating in. So Krisha talking earlier about a £6.9 million reduction in temporary staff spend, that actually equated to 18% reduction on the previous year, which wasn't about losing jobs, it was about filling jobs with permanent staff. And in my view, we've still got a long way to go. If we continue to fill our jobs with permanent staff, the quality of experience for our patients is better, but staff satisfaction is better as well, because you're working with colleagues that you work with on a consistent basis rather than temporary ad hoc workers. So there's a lot that we can do. We're going to continue to focus on training and development. As I said, appraisal is going to be key. But in reality, what I can't do is take away people's uncertainty, but we can open up the communication and the dialogue with staff to make sure that people at least feel that they're getting an honest and open answer from their chief executive, which isn't necessarily always the case in NHS organisations.
Yes, the gentleman here in the blue shirt.
Yeah, I just want
There's a microphone coming, so
Oh, come on again. Is it?
then everybody can hear you.
Thank you. Well, what I want to, this is a different question altogether. What I'd like to know, can you tell me why doctors or surgeons don't like, perform on, do hip replacements for younger people? My son is 40 years old, he's doubled up in pain, he gets very little off the social thing. He's going to lose his home, he can't work, and why can't he have an operation? He's coming back here in September, and he knows they're just going to tell him the same thing. They won't do it for him. And there must be a reason for this, isn't? The kid's going to lose everything, and it's heartbreaking.
Yeah, no, absolutely. I think that does sound like a very difficult situation. I mean, what we can do, sir, is take the details and see if we can understand a little bit more of the case. It's difficult to make a generalisation in answer to your question where it's quite a specific case, and each case is quite different. So if we can take some details from you afterwards, and we perhaps look into it for you.
Thank you.
Anybody else got any questions? The other side of the room, maybe? No? Okay, well, thank you.
Well, yes, I was there.
Yes.
Have you got the
There's a microphone on its way.
the microphone? Well, I'll just speak. It's really rather on the financial side, where you're heading again to try and overcome the deficit, with the complications of Epsom and the split with St Helier. And a lot of it is there is obviously a movement of staff in and out here. And even if you budgeted for the next 9 months, well, for the whole year really, how are you going to monitor and adjust the movement of staff to cover this, the deficit intention?
Good question. Important point, and one that our staff are also quite interested in the response to as well. We're in the midst of working through particularly with partners, our partner at Ashford and St Peters, exactly how we will organise the movement of staff from Epsom and St Helier Trust to Epsom, Ashford and St Peters Trust, where the team in the end decide to call that new organisation that's being formed. So there will be, any changes will be made in partnership with both Ashford and St Peters, but also with our staff side colleagues and with our staff. So there won't be any financially driven decisions. It will be very much based on what our staff currently do, how much time they spend at Epsom, how much time they spend at St Helier, and we'll organise it in that way, because to do otherwise would be a bit of a nonsense and would perhaps undermine the continuity of clinical service during the transition.
Yes, I was just querying the budget that you're
so
working
we've been working
and keeping it tight.
Yes, absolutely. So we've been working all of this financial year effectively with a financial picture for Epsom and a financial picture for St Helier and Sons. So it goes back to my earlier comment about the complexity of the agenda that we're working on. No other multi-site trust monitors its site-specific detail in such a detailed way in preparation for the split. So we are keeping a very close eye on it. We're reporting to the board at every board meeting on exactly the position on the site split, and there's been some external assurance to make sure that we're calculating it in the right way, so that people are clear on how the finances will split when we demerge.
Okay, thank you very much.